Hello everyone. Today I am excited to present our work on 2D ultrasound to 3D CT image registration for liver ablation surgery. This research addresses a critical challenge in aligning 2D ultrasound frames with 3D CT volumes, ensuring precision during minimally invasive procedures. To guide you through the journey, I have structured the presentation into five key sections. One is overview, where I'll introduce the motivation and the significance of the study. Second is methodology, a detailing of our approach. And the third is dataset and pre-processing, a look at the data we used and the preparation steps. And the fourth is result, showcasing the performance and outcomes of our approach. And the fifth is summary. Let's begin with overview to set the context for this study. Liver ablation surgery is a laparoscopic surgery which is used to treat liver tumors by destroying cancerous tissue using heat. During the procedure, an ablation probe is guided to the tumor site, often with the aid of imaging modalities like ultrasound and CT scans. Here, the image video on the left shows the real-time ultrasound with probe movement, and the image on the right shows the 3D CT scans. These are the inputs for our approach. There are two fundamental issues related to this surgery. One is tumor localization and monitoring, and the other one is inadequate visualization of critical structures like blood vessels. These challenges make it essential to align imaging modalities such as ultrasound and CT. Traditional methods often relied on manual techniques or external tracking systems can be time consuming or needs high expertise knowledge, particularly in complex multimodal scenarios. To address these limitations, we leverage deep learning for 2D ultrasound to 3D CT multimodal image registration. Deep learning offers the ability to handle diverse imaging modalities by learning robust feature representation, enabling precise alignment and improving surgical accuracy without the need for additional tracking systems. Let's look about the literature review. Multimodal image registration plays a crucial role in medical imaging by integrating complementary data from diverse imaging modalities. However, most exciting 2D 3D registration methods depend heavily on external tracking systems. Let's focus on methodology sections. Our project involves two main blocks. One is first frame registration, which is aligning the first ultrasound frame with the CT volume, and the other one is consecutive frame registration, aligning the subsequent ultrasound frames by leveraging the previously registered frame. Now we will focus on first frame registration. We propose two methods for this. One is iterative automatic and the other one is manual method. First, let's look about iterative automatic registration. This is our architecture for iterative automatic methods. It contains several blocks. First block is getting best matching CT slices. To tackle multidimensional nature of CT data, we reduce the 3D CT volume into 2D CT slices along the axial direction. Then these slices along with the 2D ultrasound images are used to train a CNN autoencoders. The autoencoders reduces the 512 into 512 image dimensions into a compact feature space of 128 into 16 into 16 for efficient processing. The encoder contains 5 convolutional layers and the decoder mirrors with these transpose convolutional layers. Both use Stanage activation and batch normalization. After training, the encoder extracts feature spaces for each CT slice and the given ultrasound image. We compute Hossain similarity to identify 50 consecutive slices, which are most similar to the ultrasound image. By narrowing our focus to these slices, we dramatically reduce computational overhead without sacrificing accuracy. Second block is getting best match key points. To establish correspondence between images, we employ SuperPoint, a self-supervised framework. While originally trained on standard images, SuperPoint performs excellently well on medical data, detecting key interest points in CT and ultrasound images. For robust feature matching, we use LightGlue, local feature matching at light speed. It revolutionized the process of matching local features across images using deep learning techniques. It leverages superpoint or shift or disk to extract local features from both images, each comprising a descriptor and a key point. Initially, LightGlue yielded a suboptimal results for our datasets, so we follow a training approach for LightGlue, customizing the loss function and transitioning to a supervised learning paradigm by incorporating actual matching features into the loss function definition. I will now explain the details of this customized loss function. The distance between the predicted feature points in the ultrasound image and their corresponding actual point is computed. Then this distance is augmented by the distance between the corresponding matching points in the CT image. Then, predicted pairs are classified as positive and negative based on the calculated distance. If the distance is less than the threshold value, we consider it as a positive pair, else negative pair. Light blue model generates matching score for each predicted pair. We normalize this matching score to be in the range of 0 to 1. Positive pairs are weighted by 1 minus matching score and the negative pairs are weighted by matching score. The aim of this customized loss function is to have more matching points in the interest area and to minimize the distance between predicted and actual matching points. This general loss formulation ensures that the model optimizes not only for accurate point prediction but also for meaningful correspondence between modalities. After training, the light blue model matches features, mapping 2D points from the ultrasound to their 3D counterparts in the CT volume. To handle ambiguities, we have multiple 3D points mapped to a single 2D point. We use k-means clustering to select the most representative point. We then estimate the plane within the CT volume and then train light blue to identify matching points in both the estimated CT plane and the given ultrasound image. Homography metrics can be calculated using these matching points and 2D non-rigid registration can be done using Transec algorithm. After registering the ultrasound image, our system prompts the user to indicate satisfaction. If unsatisfied, it will reattempt by getting another set of CT slices which has the second similarity with ultrasound image and the registration process continues iteratively until the user is satisfied. We proposed alternative approach using manual registration for iterative automatic method. For this, we utilized Video Python library, which provides tools to visualize and interact with 3D CT images. By inputting the 3D CT Nifty image, the library generates an interface like the one shown here, allowing users to manually adjust and align the images with precision. After the initial registration, we simplify the process for subsequent frames. During surgery, the probe movement is minimal. We consider 8 nearby CT planes, adjusting for rotations and translation relative to the previously registered frame. Using light blue, we detect and match key points across these planes, determining the best match using the target registration error. We collected clinical CT data from patients who underwent ablation surgery at the Collabrators Center for Liver Diseases, Sri Lanka, along with ultrasound videos recorded during the procedures. For experimental purposes, we also simulate ultrasound images from CT scan. To create these simulated ultrasound images, we applied Hounsfield unit correction, normalized the CT slice, and generated a speed of sound image. Finally, we used the Strike library for raycasting, producing realistic ultrasound images as illustrated in this figure. These simulations were crucial for training our model effectively. Next is result sections. We trained light blue model using paired real ultrasound and corresponding CT images. However, interpreting real ultrasound images and identifying matching points in CT scans is challenging. We annotated matching points for about 20 image pairs and used them for training. Unfortunately, the limited number of matching points in the datasets led to a suboptimal results during testing. This figure shows qualitative results for 6 ultrasound CT image pairs. As you can see, the number of matching points is significantly highlighting the limitations of our dataset. This figure shows some qualitative results from light blue model for simulated ultrasound. It gives better results than real ultrasound as we used more matching points during training. And this figure shows some results of first frame registration. The average TRE for first frame registration was 25.48 pixel distance. And this figure shows the registered images of selected 8 planes for second frame. And this table shows average distance and angle error for different patients. This table this This table compares recent studies with our model based on angle and distance error. Even without tracking systems or 3D reconstruction, our model achieves significantly low error rates. So, in summary, our, we proposed a novel method for multimodal and multidimensional registration. We demonstrated a strong performance in ultrasound to CT registration, and we also give advanced real-time guidance in liver ablation, paving the way for better patient outcomes. And in the future work, we would expand clinical ultrasound CT datasets and refine simulations to improve real-world model performance. Thank you.